I'm going to talk about type 2 diabetes management counseling during COVID-19 pandemic. I will give brief or short background about type 2 diabetes, and as everybody knows, it's a metabolic disorder and it's characterized by hyperglycemia. This can due to insulin resistance in peripheral tissue or insulin deficiency. It is also an inflammatory disease, and it has various etiology and accompanied with disturbance of carbohydrate, fat, and protein metabolism. We have some inflammatory markers that elevated when the patient has uncontrolled type 2 diabetes or type 1. So that one, it will be high interleukin 6, high TNF alpha, and C-reactive protein. So this will be crucial during COVID pandemic because infection also could trigger this inflammatory markers. So I want to give brief background about the risk of diabetes. Sedentary lifestyle is the most important factors that could lead to obesity and also type 2 diabetes. Family history, being older than 40 years of age, ethnicity and history of gestational diabetes. During COVID-19 pandemic, it's really challenging to treat people with diabetes and COVID-19 severe illness. So COVID-19 appears to develop severe manifestation of diabetes, not only DKA or HHS. It could be a typical presentation of mixed DKA and HHS. So uncontrolled diabetes mellitus is a risk factor for infection, and generally, since COVID-19 can trigger this, as we mentioned before, the response of interleukin 6 to the viral, so it will trigger this response. Pharmacists could play a crucial role in the counseling for diabetic patients. This is our talk today. We'll talk about the risk factor of COVID-19. Patient with type 2 diabetes is more likely to have serious complication, more intensive care unit administration, or longer hospital stay. And finally, death with COVID-19. Age and obesity is additional comorbidities are strong correlate for severe disease in diabetes, and there is an observational analysis assure this relation between age and obesity, but this relationship is unclear. Both diabetes and obesity appear to be independent risk factor for severe diabetes. Okay, but it's mainly obesity, mainly linked, it's controversial to age, but diabetes is increased with increasing age. So it's really a controversial link. Nevertheless, obesity has a pro-inflammatory state, which has high inflammatory markers, which could affect the respiratory mechanism during acute illness and prolonged hospital admission, ICU, and respiratory failure. There is some studies shows that fatality rate in COVID pandemic. For example, in China, the case fatality rate was 7.3% among patients with diabetes, mainly type 2, where in other cases the rate is lower, which was 2.3%. And there is a retrospective study from the US. The mortality was 14.8 among patients with diabetes and 28.8 among patients with diabetes and uncontrolled hyperglycemia, compared to 6.2% without either. Another analysis from a national diabetes mortality from the United Kingdom. Before and during the pandemic, there are over 10,000 COVID-related deaths in people with diabetes, and it's mainly type 2 diabetes. And the mortality risk was higher with the A1C elevated. So it's better to make sure that the patient hyperglycemia is controlled during this pandemic. And this is the role of healthcare provider to make sure that all the visitor or the patient who's visiting the clinic to make sure that they have controlled blood sugar to avoid the risk of severe illness. Also, elevated BMI was also associated with increased the risk and mortality. For example, if BMI higher than 13.5 till 13.9, 35 till 39.9, they have high risk of COVID-19 infection and mortality. And in a small observational study in France, 1,317 patients with diabetes hospitalized pre-admission, their A1C was significantly associated with poor prognosis and mechanical ventilation and death within 7 days of admission. As we mentioned, clinical pharmacists have a role in and was essential member during COVID-19 with the multidisciplinary team in the primary care setting or hospital admission. And their role is to increase awareness about relevant concept and give enough information and how to avoid infection or COVID-19 infection, how to modify their lifestyle changes, weight reduction. This is really important because obesity in Saudi Arabia is high. And while you reduce your weight, you will be safe and have less complication when you have the infection. Improve patient adherence to medication is really important. And this is really the role of pharmacists. Optimizing medication therapy without compromising efficacy and assuring patient safety, avoiding side effects, as well as telehealth was implemented at the beginning of the pandemic, and there is a role of the clinical pharmacist on counseling the patient during the phone call, and that was through the call center. The goal of therapy or goal of the treatment for patients with type 2 diabetes and COVID-19, there is no data to inform that there is a precise glycemic target for this specific population, but generally the goals will be the same as other hospitalized patients, that to avoid severe hyperglycemia, volume depletion, and electrolyte abnormalities, as well as to avoid hypoglycemia. It could be the target from 140 to 180. This is reasonable and acceptable. And most hospitalized patients that have good control for their blood sugar during admission, they have reduced mortality compared with poorly or uncontrolled patients. And pharmacists should encourage their patient to do changes for their lifestyle. As you know, our community have very bad sedentary lifestyle, and it's recommended that at least, according to the ADA, at least 150 minutes from moderate to vigorous intensity exercise per week, or there is some recent clinical trials shows that twice a week exercise is enough for to avoid and change your lifestyle. This combination of aerobic and resistant exercise, and at least 10 minutes at the beginning of aerobic, then increase to 20 or 30 minutes of aerobic exercise. And you have to make sure that other comorbidities could affect your recommendation. So, for example, if your patient has osteoporosis, you have to just suggest not to do resistant and give them a recommendation for lightweight sparing activities, such as walking or hiking, as well as diet is important as together with exercise. This to avoid any elevation, especially for this population who have newly diagnosed or pre-diabetic as well. And as Dr. Hana mentioned earlier in his slides, this will minimize the cost of being diabetic and cost the government a lot of money to treat you and give you medication. So it's really good chance. And in the setting of hospital admission for acute illness, NICE and Diabetes UK recommended that oral and non-insulin injectable diabetes agent either contraindicated or not tolerated during the acute illness. And some of your home or the patient home diabetes medication, usually DC, especially SGL2 inhibitor, it should be DC due to the increased risk of dehydration and volume depletion. Metformin as well is recommended to DC where renal function is either impaired or threatened due to high risk of lactic acidosis. And as well, if there is a risk of sepsis or severe infection and shock, it should be DC. Therefore, it should be DC for a while to avoid avoided in the acute illness. And then after discharge, it can be the patient could go back to metformin and educate the patient how to differentiate between DKA and GI symptoms. GLP-1 analog often cause like metformin, they cause nausea and vomiting and should be avoided during acute illness. As they mentioned before, insulin is the preferred treatment for hyperglycemia in patients who's hospitalized with moderate to severe COVID-19. And if they don't have, even if they don't have DKA or HHS, and this need in type 2 diabetes for insulin is temporary, so they can follow the patient up in the clinic after discharge, and then they can decrease their insulin requirement until the patient control, then switch to oral hypoglycemia. As well as there is another issue in hospitalized patient, the continuous tube feeding, IV corticosteroid, and the prescription of vitamin C could affect and increase the glucose variability. So the healthcare provider should decide a suitable pharmacological care plan for these patients. On discharge, we need to educate our patient. First, before the education, we need to change or stop some medication that they were used in the hospital according to their the healthcare provider decision. And if the patient is steroid and they reduce their steroid medication, we need to educate the patient if he's in insulin to minimize his insulin doses to avoid hypoglycemia, and ensure that the patient doing self-monitoring blood glucose at home and able to adjust their insulin regarding to their level, and as well educate the patient to manage hypoglycemia, which is really important after discharge, if they are especially on insulin or sulfonylureas. After discharge, the patient will come to ambulatory care clinic. So type 2 diabetes and COVID-19 may the patient, they may be able to continue their usual, if they are on the clinic, their usual diabetic medication based on their symptoms, and if they are able to eat. The most important thing, if they are able to eat. So the patient who are unable to eat, so they won't take their medication, or if their blood glucose are very high, so we need to add at least intermediate acting or long acting insulin to their medication. Keep your patient hydrated, educate the patient that they need to drink water or sugar-free drinks regularly, this specifically during sick day rolls, and manage their diabetes during illness. Advise the patient, as we said, to do twice daily self-monitoring blood glucose, and more often if they are on insulin therapy, as well as educate the patient to check their ketones if their blood glucose are very high. Oral and injectable medication, they might require adjustments according to their blood glucose trend, their diet, and advise them to advise the patient to check their feet daily if there is any breaks, any change in color, and then if there is any problem, they should wear protective footwear and seek advice from their healthcare providers. There is potential adjustment in the pharmacological therapy after discharge. So as we explained before, patients with diabetes at high risk of DKA or HHS. So most of our, in most cases of mild COVID-19 infection, we should follow our regimen as anti-diabetic medication as usual, except sodium SGL2 inhibitors, which is extremely harmful during severe dehydration, And pharmacists need to educate patients to help them how to manage these symptoms and assist them to reduce the risk of acute complication during admission and after discharge. We'll start with insulin. So the insulin requirement is estimated to increase during acute illness, as we mentioned before, and due to the upregulation of the cortisol as counter-regulatory hormones, and this patient who has significantly high blood glucose may need increment of their insulin requirement, who were on insulin by 10 to 20%, and as we said, more frequent checking their blood glucose and monitor their carbohydrate intake during the time of acute illness. Metformin is the first drug of choice, as according to many guidelines, due to its efficacy, lower hypoglycemia, and the benefit on weight loss. However, the GI symptoms could worsen the risk of dehydration and impair renal function. So it's temporary DC during the illness and the acute illness, especially. In the absence of acute illness, so the pharmacist should educate their patient about proper management of GI symptoms to avoid the overlapping with dehydration and decay. Sulphonyl use or megalotnide, it could cause hypoglycemia. So we don't advise to give it to the patient who are not eating. However, if their blood sugar very high, higher than 200%, so 200 milligram per deciliter, so we advise them to continue and important checkings and
Dr. Nawal, the sound is not clear.
Sorry, it's not clear now. They have favorable cardiovascular and renal outcome among patients with diabetes, and they have benefit on weight reduction. But the presence of acute illness, hospitalization,
Dr. Nawal, your voice is going off and in. Can you please just readjust your speaker? Thank you.
Okay. Now it's clear?
A little bit better. Yes, you can go ahead.
So we recommend that temporary DC to reduce the risk of developing DKA. If it's mild illness, so just keep going on SGL2 and maintain normal diet and enough food intake. Generally, patient on SGL2 should be adequately educated by pharmacists on how to recognize sign and symptom of DKA. We're moving to DPP-4 inhibitors. Some, as we know, it carries an anti-inflammatory action and reduce the severity of inflammation, acute complication. But on the other hand, it can activate T cells and promote or worsening the inflammation. So accordingly, it shouldn't be used as protection against COVID-19 or shouldn't be DC. That excluding the known reason for discontinuation. There is other reason for discontinuation, so we recommend to discontinue this medication. And as well as according to not enough clinical trials regarding this reporting, there is a large need or a huge need for a large scale data to confirm the assumption of this finding. GLP-1 receptor agonist has been markedly rising use considering its cardiovascular benefit and the lower hypoglycemic risk and its impact on weight. However, patients experience nausea and diarrhea should be withheld GLP-1 to avoid dehydration, and nevertheless, patients should be adequately educated to recognize as well the symptom of DKA. As such, if DKA or pancreatitis is suspected, so it should be DC. Pioglitazone is having an anti-inflammatory action but it could lead to fluid retention that could further complicate the management in diabetes patients, especially people with cardiovascular disease or heart failure. So moreover, it might cause weight gain, and during pandemic, patients already at risk of weight gain due to their sedentary lifestyle. So basically, pioglitazone should be among the least recommended option during COVID-19 pandemic. Hydroxychloroquine has been initiated in many countries as prophylaxis against COVID-19 infection, and it's reduced the viral load as well as HbA1c. However, it might cause hypoglycemia, and in addition, with metformin, it might cause potential toxicity. Long-term use in patients with diabetes is correlated with fatal cardiac arrhythmia and retinal toxicity. So we have to make sure not to use this medication with medication with other drug that prolong QT interval, for example, antiviral, macrolides, and antihistamine. Therefore, a careful risk-benefit assessment should be performed. Statin therapy has been integrated as integral component of cardiovascular prevention among patients with type 2 diabetes, and it has anti-inflammatory effect that could help in the management of viral illness, and it has been listed as off-label use in some of the current COVID-19 treatment protocols due to their immunomodulatory effect. However, statin may exhibit drug-drug interaction with some antivirals. It could be so the current evidence, however, does not indicate the need of discontinuing this medication when the patient with COVID-19 and diabetes. Other medication, for example, ACE inhibitor ARBs, if patients are dehydrated, so this could cause renal impairment. So we suggest to discontinue this medication, as well as non-steroidal. For diuretics, it depends on patient situation and other comorbidities. So if the patient using 2 diuretics, he might seek medical advice before stopping one of them. And clinical pharmacists or the pharmacist generally needs to act proactively to ensure that the patient has enough supply during the pandemic to avoid unadherence or uncompliance to their medication. And therefore, they expected to extend the scope of remote mobile. That's why we do have delivery for the medication, home delivery during the pandemic, which helped most of our patients, even outside the Riyadh, to have enough medication during that time.
Dr. Nawal.
Yeah.
Yes, that's great. We are just wrapping up, aren't we? Because we do have a few more minutes, and then we will be going to the Q&A session.
I finished. This is my conclusion. So evidence suggests that involvement of pharmacists in diabetes care has been linked to positive impact on the clinical outcome for the patient, and they can effectively contribute to overall optimization of diabetes care through safe and optimized medication supply, and as well as the important to ensure better adherence to achieve better glycemic control. Thank you very much for everyone.